Okay, we're going to go ahead and get started. Hello, everybody, and welcome to another session of virtual Global Spine Conference. I'm happy to be here along with some of our colleagues, our co-hosts and faculty, and really delighted to welcome our guest today. With us today is Dr. Avelino Parajon. He's the head of the spine section in the neurosurgery department in Ramon and Cajal Hospital in Madrid. Dr. Parajon really doesn't need much of an introduction. He really is an international figure in spinal neurosurgery. He's on the leadership committees of the AO Foundation, AO Spine, recently the ISAS. He is a very well-known scholar and surgeon, and he's a terrific educator and really a researcher and a scientist. I've had the pleasure of meeting him for the first time in New York City a few years back, and since then we've had a great relationship in terms of collaborating in meetings and conferences. He brings a lot of innovative ideas to both his practice and his training and his research. He is really a great spine surgeon, but I think he devotes a lot of his time to minimally invasive spine surgery, for which he has done a lot of work on the MIS task force for AO Spine. So it's absolutely a pleasure to have him here with us. He can talk about so many topics very competently, but I think he chose today to talk about the direct Trans-Psoas approach and how, and really the current role for it in the setting of pre-psoas, anterior to psoas approaches, prone lateral. He's going to talk to us about all of that. So needless to say, I hope I didn't scare him off because I saw that he just logged off. So we will give him another minute to log back on and we will start the presentation. I want to welcome everybody for some of our new colleagues here. As you know, this is a weekly conference every Thursday. This is recorded. And you can certainly view all of these sessions on our YouTube channel later. So let's see, Dr. Parajon, if you can hear us and you're ready to go, please feel free to start.
You hear me now?
Yeah, perfect. We can hear you. We can see you. Just go ahead and feel free to share your screen. Thank you so much for joining us.
Okay, first of all, thank you for your introduction. I think you were very kind, as you're a good friend. So good night from Madrid, Spain. These are my disclosures related to LLIF, to Trans-Psoas approach. First of all, I want to thank you, your kind invitation. It's a big honor to be part of this educational program of virtual spine. I think you are doing a very, very great work for these last years. But I think that I'm sure you have invited me because we share the same taste in shirts, obviously, as we can see in this picture we took in Boston. So as you mentioned, I'm a neurosurgeon from Spain. I work in Madrid in a public university hospital in Ramon y Cajal. Is one of the biggest hospitals in Madrid. For those who don't know, Ramon y Cajal was the winner of the Nobel Prize in Medicine in 1906 for his contribution to neuroscience. So he was one of the discoverers of the neurons and synapses and so forth. So extreme lateral interbody fusion, XLIF, DLIF, LLIF, Trans-Psoas approach is a relatively new surgery. So we have been dealing with that for the last maybe not even 2 decades. And it has meant for spine surgeons the necessity of learning new anatomies, new anatomical concepts like superficial nerves and vascular structures, and especially for neurosurgeons, we were not used to deal with these structures. Surgical technique has evolved since the beginning, being at the beginning, at that moment, a specific procedure to insert a specific implant from a specific company. So I think that was the reason that something needed to be changed, and also we have changed even the name, not to be related to just a single company. So the surgical technique has been standardized thanks in part to the work of some groups, like, for example, the one you mentioned before, the MIS task force, involved in the standardization of the minimal invasive surgical techniques. So in the technique proposed by our group, for example, we can consider 10 main steps, and we can consider some mandatory instruments that we think are needed for the procedure. The first step would be the positioning of the patient. So positioning of the patient in the OR is crucial, and I think this needs to be explained to all the team, to all the surgical team. So we need to explain to the anesthesiologists, to the nurses, that we are going to spend some time positioning the patient, because positioning the patient will save a lot of complications, radiations, and so forth during the surgery. So I would say that the second step would be confirm that we have perfect orthogonal images of the spine in order to save time and to save radiation during the procedure. Next step would be the incision localization. This usually can be done with X-rays, but in some cases we can use navigation. I think from my personal point of view, probably lateral Trans-Psoas approach is not the perfect surgical technique for using navigation, as it's a very dynamic surgery. So probably you will need to do many spins during the surgery, especially if you are doing several levels. So probably navigation can help in some complex surgeries, as we will see later, but not for the everyday single cases. I'm talking about this specific procedure. So muscular planes identification help in orientation during the surgery, and we will dissect those 3 layers, obviously not cutting them. This is why this technique is a very minimal invasive techniques, as we don't damage any muscles of the spine or the abdomen. Neuromonitoring, from my personal point of view, I would say it's mandatory, but at least it's highly recommended to prevent neural complications. So the next step will be placing the sequential dilators, and as how we do in posterior approaches. So every company has different sequential dilators, and finally we will drop the expandable tube. And as soon as we drop the tube and we open it, we ask someone of the team to start counting time. So we don't want to have the retractor open more than 20-30 minutes per level to prevent neural complications. And this is something that has been recently published by some authors, and it's something that we learned also during time. So we have been having less complications since we started doing this monitoring the time. So all companies provide nice tools to make the complete or almost a thorough discectomy, and I think it's a matter of preference of the surgeon to use any of these tools. And then finally, the implant is inserted, and we confirm it with AP and lateral X-ray to confirm the final right position. Additional fixation is recommended in most of the cases. We will discuss also later about this, but it can consist on pedicle screws, either percutaneous or open. And we can also use lateral plates with several screws, or even some companies provide some other types of fixation like interspinous or whatever. Usually patients start working after 6 to 24 hours of bed rest, depending on the severity of the rest of the procedure. For a single level, usually patients can walk after 4 hours, and they can be discharged from hospital in 24 or 40 to 48 hours after the surgery. So if you see the challenge of the surgical technique, main challenges are related to avoiding complications such as neural damage, as well as muscle damage or pseudoarthrosis, and with an adequate follow of the steps, the surgical steps, this can be avoided. The main indications, I will say, in our daily practice are adjacent level disease and adult deformity. But I will say that any type of instability that has also associated stenosis that can be addressed with indirect decompression is a good indication. Contraindications, I will say they are mostly relative because, for example, L5S1 is, I would say, complete contraindication, but in some cases it can be done. We have done it before we will learn another lateral approaches. And for example, this is a case in which L5S1 was initially planned to be done with ALIF, and then we realized during the surgery we could do it without any vascular or neurological problems. So we finally put a lateral Trans-Psoas cage and L5S1, but obviously it's not the best indication. Lock facets also considered as contraindication. Now, some authors, like this nice paper from Roy Hartels and his team, show that it can be also a good indication for decompression. So, lateral Trans-Psoas fusion shares with other interbody fusion techniques the common advantages of increasing the fusion rates, improving the sagittal balance, and indirect decompression, but has some other specific advantages. Like, for example, it has a great potential for coronal balance correction. This is why one of the main indications nowadays is adult deformity surgeries. So ALIF has become one of the main weapons in adult deformity surgery. We can see here some simple cases of deformity, adult deformity, in which we used lateral cages and then a posterior fixation. This is another case in which one simple cage was able to gain a very good coronal correction. Fusion rates obviously is if we consider or if we compare the size of the PLEAF or the TLIF cages with the size of a Trans-Psoas cage, and also the amount of disc that we are able to take out from the posterior approaches and the amount of this we are able to take out from these lateral approaches, it's easy to see why we are having a very good fusion rates. And this is something that always has been a criticism from surgeons that they don't believe to say that in minimal invasive techniques, that obviously there are many papers showing, and we can see in this post-op CT how this technique can provide a nice fusion rates. Indirect decompression as well is at the beginning it was like a matter of faith, and there was big discussion between surgeons about indirect decompression. Now we have a lot of papers, and these are some MRIs from our personal experience showing that this is a nice technique to provide indirect decompression, and we don't need any additional direct decompression in some cases like this one. So I would say that the initial recommendation for people starting to do these techniques, I would say that the best cases probably will be adjacent segment disease, like L2, L3, or even better L3, L4, like this patient we show here, that patient with the previous fusion and now has severe stenosis on L2, L3. So in this case, we put lateral Trans-Psoas cage with a plate, and you can see the amount of the indirect decompression in the postoperative MRI, and we can also see that even the coronal balance has improved if we compare the sequential image studies from the initial first surgery that was done many years ago somewhere else, and the XLIF or Trans-Psoas approach that we did. But Trans-Psoas approach can also be used for more complex cases once you have gaining confidence with this technique. And this is, for example, a complex case that we did 2-level corpectomy, L1 L2, through a Trans-Psoas approach. And this, in some cases like this, are, I would say, more technically demanding, as you have to deal with the ribs and and with the insertion sometimes of the diaphragm and so forth. But I think it's a very nice tool to do a minimal invasive approach, and then we were able to do a complete resection of the tumor from a lateral approach and a nice decompression of the canal, and then I put some percutaneous screws to complete the stability of the case. But like every other surgical technique, there are some downsides or some disadvantages. So I would say one of them is neurological complications. Maybe the inability to provide decompression in some cases, being able to create lordosis, how to manage multi-level surgeries. In some cases, these are long surgeries. Sometimes it takes a lot of time between moving from lateral to prom, especially depending on different hospitals. And some surgeons have said, well, maybe we need to move to another approach, like the Trans-Psoas, to avoid those complications. And I think in Spain, there are some spine surgeons moving from lateral to lateral Trans-Psoas to lateral or anterolateral Trans-Psoas because they had previous bad experiences with neurological complications. I think neurological complications have been one of the main cases why some surgeons are not adopting these lateral Trans-Psoas. And initially, the paper showed a very high rate of neurological complications, 12% and even 25% in some cases. I remember the first time I attended a conference on this lateral approach, and I saw 25% of neurological complication. I say, well, I will never do this technique. But obviously, after the years, we have been improving our knowledge of the lumbar sacral plexus anatomy, and there are many nice papers and this picture that you have seen in many presentations. But it helps a lot in giving you an idea or a special orientation on when to start your approach, depending on the level you are working. I would say that
Avelino, can
yes?
Hi, sorry to interrupt here, but I think we already have some really good questions from some of the
Yes.
audience members, and I know you're going to probably address some of those, but it's a good point to maybe just engage some of our participants. So you showed that you showed that case with adjacent segment disease. Obviously, that's going to bring up a lot of questions and a lot of interest because it's a common scenario. You know, what's the best thing to do at the, you know, when you have adjacent segment disease? I think a few questions here. In your experience, you've done a lot of these, and you're very well read up on the literature. Can you talk a little bit about, you know, I know initially I was one of them. I was doing just standalone cages for adjacent segment disease. Then folks said, well, maybe that's not enough. Maybe we should put a plate. Others are, no, we should also back it up with screws. Can you comment a little bit about your decision-making in adjacent segment disease? When do you just go lateral, and when do you augment that with either lateral screws, plates, or even posterior?
Well, now I never do, I would say, single cage without at least a plate. And I think the main indication for standalone, considering a standalone cage and a plate, would be adjacent level. If the patient doesn't have severe osteoporosis, this is not a very old patient, or I think it's a very good tool. Just put in or very good technique. Just put in the cage and the plate with 2 screws. Sometimes, as you know, you are not able to put a screw in the lower level, and sometimes this must be a problem. I have had some bad experience. I was going to show later one case in which I thought this was going to be enough, and then after some time the patient came back because there was a subsidence, and in the literature there are some reports about that. I would say that for deformity, for spondylolisthesis, or for osteoporosis, definitely you need a posterior support. This is my personal point of view on how we do these cases now. Okay,
and 2 more just quick questions. You know, you hear a lot about the Mickey Mouse ear, especially at L4-5, and Dr. El-Shamiri asks, he didn't see it as a contraindication. Do you feel that's a contraindication, or do you feel now there are techniques laterally to safely do lateral interbody fusion despite those high rising or Mickey Mouse psoas muscles?
Well, I think in most of these cases, from my point of view, if you have a very good team of neurophysiologists and they are experienced and you have done many cases, and I think this is our experience, you can deal with these cases. But in these cases, probably you need to do a bigger incision and try to do a direct dissection of the structures, not just doing like blind dissection and dropping the tubes without trying to identify it in some cases, because sometimes you do the neuromonitoring, the local mapping, and then you once and again find nerve, and finally you are able to dissect it under direct visualization. So sometimes I think it is very helpful.
And just one last, oh, go ahead, I'm sorry.
No, so I will not consider it as a definite or absolute contraindication, no.
Okay. One last question, and then we'll move on. Dr. Burchik asks, as far as tumors are concerned, do you think en-bloc resection is possible through a Trans-Psoas approach or through a lateral approach?
Well, in a case like this, for like a chordoma, to be honest, I've almost never been able of doing a in-block resection with chordomas, because you are always dealing with nerves around, with vascular structures, with so many delicate structures that I think it's almost impossible, at least to me, to make an en-bloc resection. But I think for this upper level lumbar levels, you have a very wide exposure with the trans-psoas. I think because the psoas here is thinner, you don't have nerves, so I think you have quite a good space to do not an en-bloc, but a very good complete or almost complete resection of the tumor.
Okay, thank you so much.
So continuing with the neuromonitoring, as I was saying, now what we do is we do this for monitoring. So we do the local nerve mapping. So we have a stimulator that we directly use to stimulate all the zone between the blades of the retractor. Then we use the free EMG continuous monitoring, transcranial evoked motors, and somatosensory evoked potentials. And as I said, I took a picture of the neurophysiologist because I think it's very, very important. And I have the bad experience of doing some surgeries in some private hospitals around, in which I couldn't bring my own team of neurophysiologists, and I didn't have the same good results, or at least I wasn't so confident during the surgery. So I think making team with the neurophysiologist and doing cases with them, I think is very, very important. Another interesting point that we have learned with time is about the importance of the adequate positioning of the cage in order to provide a good decompression. So now we know that the more posterior we put the cage, maybe we will have less lordosis, but we will have probably a bigger or best indirect decompression. And another thing is the importance of using wider cages. I think using wider cages is much better than using high cages. At the beginning, we use 14, even 16 high cages in millimeters, and we have lots of subsidence and even probably pain from retracting so much the root from using so high. So higher cages. And now we learn that, and there are some publications like again this one that, as you know, Roger is always and his team doing a lot of publications, and they publish that probably is much better using wider than higher cages. And the other point is gaining lordosis. This is something that now neurosurgeons, we have learned from our colleagues, especially from the French school and then from the school from New York. All these papers they have published, and we know that definitely gaining lordosis, or at least not losing lordosis when we perform a lumbar fusion, is essential in order to have better long-term outcomes. And of course, the best way to do it is those big osteotomies, those big surgeries. But usually those big surgeries are associated with long-term recoveries, with a lot of complications, like those patients, transfusions, being in the ICU for a long time. And so these lateral cages can provide some alternative tool to this. Maybe we are not going to obtain a perfect lordosis, but this can be a matter of discussion as well. As you know, should we put elderly people in a perfect match of the lumbar lordosis with the pelvic incidence and so forth? This is another discussion, but definitely these lateral cages can help us in gaining lordosis, and maybe in many cases avoiding those complex and potentially dangerous surgeries. But again, those minimal invasive techniques have a ceiling effect. So in some severe cases, maybe they are not enough. So again, the industry provides us some nice hyperlordotic implants, and those implants associated with the anterior column release maneuver, that means opening the anterior longitudinal ligament, help us in creating some lordosis and gaining lordosis. So I think this is very good alternative to maybe some PSOs or not PSOs, but other simple osteotomies that in many cases have a lot of blood loss and complications. No? And then again, we have many publications related to this, and definitely, if we are using those minimal invasive techniques in adult deformity surgeries, we will have less complications. This is quite obvious, and there are a lot of literature related to this. One step beyond in terms of what industry and technology provide us is expandable cages. We can see some cases of simple expandable cages here. This is a case in which the patient had a PGK, and then we just used a single level expandable cage, and as you can see, well, we were able to gain some lordosis and avoid complex surgeries. In multi-level surgeries, I think they are very good alternative, those expandable cages. Most of these cases, we do it staged, like you see here. So first stage, we do the lateral cages. We put the expandable cages, and then in the second step, some days later, or in some cases a week or two later, we put the posterior crus. We have had some funny cases. I had two cases of elderly women that we did the lateral approach, and they improved so much in their walking ability and back pain that they refused to come back for the second surgery. But I think in some cases, and this is related to the what we were talking before, these patients can have a high risk of subsidence in the future. That obviously you can't oblige them to have the second surgery. So
Avelino, again, sorry to interrupt. I'm just going to pose a couple questions. I think that point you said is very important, which is when there's an advantage to staging a procedure, obviously a lot of advantages, especially for the patient. But one thing you do have to watch out for is sometimes they don't want the second operation, right? They just barely recovered. They're doing well. I have a few of them now. I staged ALIF posterior, and now they just don't the posterior. They're doing well. So that's something really to consider on how you counsel the patients, and especially for the young surgeons in the crowd. You want to do what's safest for patients, right? So if you think there's a case that they absolutely need to be backed up, you can't even give them that option. You have to counsel them, but you probably should do it in the same hospitalization before the patient changes their mind, because they don't know any better. So you have to counsel them, you have to tell them the risks, but if you feel that it's absolutely indicated, you need to plan for that as part of the preoperative discussions, and not say, well, let's see what happens, you know. So I thought that was interesting that you mentioned that. I think we all have that experience. You mentioned the ACR, and Dr. Barbagli here with us at the University of Arizona, is one of our research fellows, has a great question. I feel like ACR from the lateral approach, you know, basically opening up the ALL resection, you know, you have a few people that talk about it. Most people say, oh no, we never do it. What is your advice on that for folks who want to do more lateral? Obviously, it's an advanced technique, it's high risk, but it's so powerful, right? Can you just spend a minute on what do you think the role of ACR in a spine practice should be?
As you said, I think it's not for the first cases, of course. I think it's something that you have to do when you have some experience. Definitely, you have to take care and take into account the potential vascular complications. So in the cases that you have planned this, probably you need a vascular surgeon to be available, same as when you're doing an anterior approach. And many companies provide some nice, like, plastic dissectors that help you to protect the vessels. And I think probably one of the main advantages of expandable cages is that they help you in doing this procedure, because sometimes you don't need to cut all the ligament. You just need to cut in the first part, the more proximal part that you can see from where you're approaching in the lateral. And then when you put the expandable cage and you open it a little bit, little by little, and it continues scratching and cutting the ligament so I think it's a powerful, but also you have to take care, and this is something that I always repeat, that the expandable cages are very dangerous because you can break the end plates, and you can even break the vertebral bodies. So you don't have to give a lot of power to the distraction, to the expansion tool. I don't know if I explain it correctly.
Yeah, no, absolutely. I think you're right. I like what you said about that, which is you really don't need to resect the entire ALL, just, you know, partially. But again, it is a complex procedure, and I think a lot of people, me included, have done it a lot unintentionally, right? You know, unintentionally or too anterior, and you open it. But it is a very powerful technique. And one piece of advice I will give is that in potentially a patient with a lot of vascular disease, if you see a lot of calcifications on that aorta may not tolerate stretching, and you don't want to cause of course, a dissection. Very rare, but it has been reported. So you have to be careful how much you stretch tense or rigid vessels, obviously, which are right there. A couple of great questions also. One from Dr. Burchick again. Can you comment on when you think indirect decompression alone is not recommended? Which cases would you say, you know what, I'm not going to do a lateral indirect decompression, I'm going to do a direct decompression? Is that a radiographic decision? Is it a clinical decision, or is it both?
Well, recently, also again, the group from Breuer published that if the main compression is in the lateral recess, probably is not a good tool to gain decompression at this point. So if the main compression is at the lateral recess, we will probably need a direct decompression. And of course, if there's this fragment or some fragment into the canal, most of the times you can't rely on the indirect. But on the foraminal compression or central canal stenosis, even if it's due to a big hypertrophy of the yellow ligament, most of the times I think you're able to have a nice indirect decompression with these lateral approaches.
Perfect. Thank you. Thank you.
Thanks for the questions. So continuing with the expandable cages, I would say that by now there's no definite evidence, and we have very few studies on these lateral cages because the technology is relatively new. But I think that they are quite easy to insert. I think they can facilitate, as we have talked, the anterior release maneuver, and to me this is very important. They can decrease complication, especially in elderly people, because sometimes trying to insert a big cage, you hammer the end plates, and then obviously you will have a subsidence, and maybe they are a tool to increase the lordosis, but this is something that we have to see. And again, coming back to what we were talking, I think that one of the most important things in order to avoid complications in those, especially in the complex cases, is preoperative planning. As you said, you have to take a look at the vascular characteristics of the aorta, of the iliac vessels. So you have to see the size and the shape of the psoas muscles, to see where your vascular your nerve plexus is, and all this. And then, of course, it's essential to do a very thorough X-ray examination, including, if possible, a whole body EOS, or at least full length deformity X-rays, and know what your goals are. If your main goal is gaining lordosis, if your main goal is decompression or whatever, and in the deformity cases, try to minimize the number of levels to operate, because we know from the literature that every additional level treated, there's approximately a 59% increase in complication rate. So I think it's very important to minimize the number of levels that we do. So as we mentioned before, those complex surgeries, we used to do it multi-level, we used to do it stages. So what we do is we put the lateral cages, and then we put the patient walking and see how, if the patient has still some neurological compression, and even sometimes we order MRI or CT. And then if we think that the patient needs additional decompression, then we can drop a tube in the posterior surgery in the second step, and make a direct decompression at this level. And I think that we are using navigation for all these posterior screws, but in this deformity cases, it's nothing related to lateral, but I think it's some nice tip that can help some surgeons. I like to use the final X-ray to see how the coronal image is, and also to be sure that all the screws are in place, that we didn't have any pull out. This can be common, or even that we put all the locks of the rods in the right position. So I think it doesn't take a lot of time to do a single X-rays. For these complex cases, some recent papers have shown that in the case that we are planning to do it all the same day, and we used to do lateral position, put the cages, and then put the patient in the prone position and add the screws, maybe the operative times and the length of the stays can be shorter if we do it all in the same position. So we have been doing for the last year those single lateral position, single position, and in those cases we are using navigation. So what we do is we put the patient in the lateral position, we put the reference in the iliac crest, then we put the screws with navigation. The lower screws, the screws of the side that is in the lower part is a little bit more uncomfortable, I would say, but with navigation, I think it's not difficult to do it. Probably with robot is much easier. Some colleagues that use the robot, they feel that it's quite more easier. And then, for example, in this case that is a single level, still we can use the pointer of the navigation to get orientation for the cage. So in those cases, we invert the order. We don't put the cage before and then the screws, but we put the screws before and then the cage, and this does make sense because otherwise we will need to do a second CT, as when we put the cage, the anatomy has changed. So this is a one level case. This is a 2 level. I think for 1 or 2 level, probably this single lateral position saves time, at least in our environment, in our hospital, because sometimes changing from the lateral to the prone position, it takes like 1 hour even. So I think the patient saves 1 hour of anesthetics, and then we save a lot of time, and I think it's good for everyone. And in the cases in which we are planning to do, for example, 3-4 Trans-Psoas and 4-5 Preoperative, like this case, for example, I think it's also very comfortable to do it in the lateral position. This is a patient with low back pain, sciatic pain, claudication, foraminal stenosis. Patient has a grade 1 listhesis in 4-5 with stenosis and foraminal stenosis in 3-4. And we thought we could try to, or we should try to maintain the lordosis as the patient has a high pelvic incidence. So according to this Russell type, probably losing lordosis in a patient will cause back pain in the future and probably adjacent levels. So we thought it was important to gain a lordosis, or at least to maintain lordosis. And this is what we do. What we did. So we did expandable cage. You can see here on the left here, you can see the image of the expandable cage in 4-5. So we open the anterior ligament, as you can see, and this is how you can see in the lower right image. We gain quite an amount of lordosis. And in this case, we use navigation for the orientation. And the navigation can help also in these cases to mark the incision for the Preoperative. That sometimes is not easy to find the right incision with the X-rays, and with the navigation, I think it's a very good tool, because you can prolong the pointer, and then you can easily see where you're pointing towards. And this is the final solution of this case with Preoperative in 4-5, Trans-Psoas in 3-4, and the percutaneous screws. Some surgeons are doing, as you know, I don't know if in your department you're doing this single position prone lateral. You know, some of our colleagues are very enthusiastic of this technique, and there are some papers showing that probably the increment of the lordosis may be bigger with this technique. Obviously, if some of the critics of the lateral single position comes from this, that if you're doing more than 2 levels, maybe you can lose some lordosis in this position. So in those cases, what we do again is second stage. I don't have experience, to be honest, with the single position prone. And I have some questions about this, because I have been reviewing the papers. Obviously, there are few papers with few cases. There is this paper by Pimenta and his group, but they only made 27 patients, and they have a high rate of complications. They have, for 27 patients, they have 3 new sensory deficit, 1 new motor deficit, psoas hematoma, and even in 5 cases they didn't do a posterior fixation. So I don't see clearly a reason to do for these 1 or 2 levels in this prone position. But obviously, I think this is something that we have to study, we have to see what the results of our colleagues are, and maybe in the future we will be doing this. As I said, 15 years ago, I thought I will never do lateral Trans-Psoas, and now I think is one of my favorite surgeries. Another downsides of these techniques are published in this paper by the group of Adam Cantor, and they found that there's a tendency to dock anteriorly the retractor when you're doing this in the prone position. The ergonomics for the surgeons obviously is not very good, and of course there's a lack of compression. So when you're trying to hammer the implant, then you need some tool to hold you on the opposite side, and then some of the companies now provide these special retractors and so forth. But I think again there are some downsides of this technique. This is the case I mentioned before, so as we already talked about that, this is a case that had a previous surgery with an incidental durotomy, and so the patient had a very bad previous experience, and the patient didn't want anything from the back, so we decided to do a lateral approach. The patient, as you can see, has a very severe stenosis with a grade 1 listhesis. So we did this this lateral cage with a plate. The plate was too short, as you can see, and I wasn't able to put the upper screw. And probably that was the main failure. Should we have put a bigger plate with upper screw, or maybe 4 screws in this case, as we were not planning to do. But this was the time in which some surgeons were doing only cages with not even plates, so I thought it was going to be sufficient. And some weeks later, the patient came again with the same symptoms, and we did a simple X-ray, and as you can see, there's clearly 4 weeks post-operatively. If you compare the left with the right, you can see that there's a subsidence and enough subsidence to give the same symptoms again. So want to consider a standalone. This is what we talked about before. Not in an osteoporotic and elderly people with in deformity, or if we have more than grade 1 spondylolisthesis, for these cases I will always recommend posterior screws. My final question is the question that some surgeons ask me, at least here in Spain and in Europe, is very frequent when we are teaching Trans-Psoas, and they say, well, why don't we do just Pre-Psoas? Because Trans-Psoas, we have seen that there are many neurological complications. In 4 or 5, sometimes it's very difficult. Well, as you know, the Pre-Psoas is very similar in many steps to the Trans-Psoas. So the anatomy is essentially the same. The muscles are the same. Something very important when we are talking about the Pre-Psoas is achieving a good orthogonal maneuvers, and we have seen, especially in the beginning of the learning curve, some severe complications because the cages were put in the contralateral foramina. So this is some a little bit more complex technique than I would say than the Trans-Psoas. But if you take a look to the literature, Trans-Psoas and Pre-Psoas have similar fusion rates, similar indirect decompressions, and in terms of complications, Trans-Psoas approach may have some more probability of neurological complications, but Pre-Psoas, you have to deal with the vascular and visceral structures, and also you have a potential for complications. And even if we are talking about neurological complications, some authors at the beginning said, well, with Pre-Psoas approach, there's no probability for neurological complications. Now that we have more and more patients, you can see that there's 1% of permanent motor neurological deficits published in this publication comparing Pre-Psoas versus Trans-Psoas. So definitely, I would say it's a matter of preference, and also probably depends on specific patients and cases. I would say that there's no ideal technique for every case or for every patient. I think all the spine surgeons must learn all these techniques. If you see, some of them are better for indirect decompression, some may have higher fusion rates, some are better in improving the sagittal balance. So I think you need to tailor to the specific case you have in front, to the level you are dealing with. So definitely, I think spine surgeon must learn all these techniques and then decide what technique to apply. So my final tips for the lateral Trans-Psoas would be patient selection. I think is mandatory as in every other spine surgical technique. Preoperative planning. The more complex is the case, the most important is the preoperative planning. Systematization of surgical technique. This is something essential to learn the technique, to teach the turning, to publish, to compare. Intraoperative neurophysiology, I think, is mandatory, especially in the lower levels, 3, 4, 4, 5. We have learned that don't break in the table and minimizing the surgical time of the open retractor is very good in preventing neurological complications. Don't use monopolar for this section of the soft tissue. Meticulous manipulation of the peritoneus. Don't violate the end plates. So especially this is more important in elderly patients. We have more and more elderly patients every day. Cage is not too high, but as much big as possible in wide dimension. And of course, take advantage of technology like navigation, robotics, expandable cages, and so forth. So these are my conclusions. Again, thank you very much, Ali, for your kind invitation. It's my honor to be here.
Thank you so much, Dr. Parajon. What a nice final slide here. I recommend everybody take a picture of this, because this is based on a lot of experience. I'm sure some good outcomes and a lot of learning tips along the way with difficult cases. Yeah, I think, great engagement, great questions from the audience. I think, one thing I would like to add, and I want your opinion on this, is as somebody in my personal practice who started out, because of obviously the folks I trained with, did a lot of lateral, and then went to posterior approach, and now the posterior MIS is just a very, very standard in my practice. I feel that especially for lateral, you really need to have consistent practice, consistent utilization, so that you, the team, everybody else knows the setup and maximizes or optimizes the success. It's just not one of these things where you want to do 1 or 2 times a year and expect good outcome. I feel like it's just one of these things where you have to commit your lumbar degen practice to it, or you're not going to be happy with the outcome. That's my only, I think, reservation about it, and I want surgeons, especially young surgeons, to consider that. What do you think, Avelino, about that? Do you agree that it's probably just so nuanced that you really need to dedicate a significant part of your practice to get the best outcomes?
Yeah, definitely. I think, as you mentioned, that is not something that you can do once a year or even once a month. And I think there are many indications for this technique, and it's a technique that you can combine with other approaches in some complex cases. So I think there's something that you can do several times every month. So all the team is aware of potential complications of the workflow, and especially the neurophysiologists, again, they can have some experience and provide you their inputs, because they were the first that told us maybe we could close the retractor for some time in some complex cases and see what happens. And then we saw that was much better. Or maybe you shouldn't break so much at the table. And then we saw this in the paper. So.
Yeah, no, absolutely. And I'd like to welcome Dr. Selby, who's one of course, our co-hosts from Australia. He had a good point. a lot of us on this forum, we debate, MIS TLIF, open TLIF, anterior. So we have people on all sides of the equation, and he's absolutely right. Anything really MIS or anything nuanced like that, you need to do quite frequently in order to do well in. But I will say, from a practical perspective, I think we're still learning so much about the lateral approach. And some people say, keep the retractor close to the nerve. Others say, no, be anterior and push the muscle back. There's a lot more variability with the lateral approach than the MIS TLIF approach, in my personal opinion. But both of them have to be done frequently to get a good outcome, of course. Okay, great. Well, Avelino, thank you so much for everybody who's keeping track of the time. It's almost 1 a.m. in Madrid. I don't know if he's operating tomorrow or in clinic or day off, but we're not going to ask. We're not going to ask.
Okay, thanks.
I'm sure you'll be ready for whatever you have tomorrow. We have several colleagues today. Really, the audience every week is phenomenal today, especially with such a diverse international background. Thank you, everyone, for joining us. This will be again recorded. We do have to double check that there were no names on the x-rays, so we'll check that on our end. And if there's no names, we'll put this talk online. Otherwise, thanks to everyone for joining us, and we will see everyone again next Thursday. Thanks, Dr. Parajon, and thanks to everyone who joined us today.
Thanks.